Hi, I'm Nikki Keefe with the Vein and Lymphatic University Voices podcast. I'm interviewing both Dr. Kush Desai, who is a professor of radiology, surgery, and medicine at Northwestern University, as well as Dr. Jim Benenati, who's the chief medical officer in Penumbra. We're going to talk today about one of the abstracts that was submitted and accepted to SIR this year. Very excited to hear more about it. It is titled Computer-Assisted Vacuum Thrombectomy versus anticoagulation for iliofemoral deep vein thrombosis treatment, a comparative analysis of hospital and post-hospital outcomes. So thank you both for joining me today. So Kush, if you can start off with telling us kind of what the impetus behind this research project was.
Yeah, sure. One of the things that I think we've all grown to realize is that with DBT, we have actually really high quality data in the form of ATTRACT. And then, predating that, we have CAVENT. And so you have two RCTs. CAVA is another one, a little bit smaller. But basically, these are trials that have kind of honed down which patients benefit. But what they haven't shown is how modern technology plays a role, not only in the patients that have been shown to benefit, but how it impacts, sort of real world tangible outcomes like when do they get discharged? What does it mean in terms of cost and all that? And so what we wanted to show is, we're no longer really lysing patients with the same degree, the same frequency that we were, multi-day lysis that we did see in CAVENT, that we saw in ATTRACT. We're now doing a lot of on-table thrombectomy with a variety of devices. And what does that mean for patients in terms of how quickly they're discharged, where they're sent, how that impacts, sort of an economic outcome. And so that was the goal behind this to see, how one device specifically that has a lot of use, computer-assisted vacuum thrombectomy in DVT impacts healthcare outcomes, vis-a-vis discharge and, quality of life and really economic impact.
So Jim, thank you to Penumbra for opening up your data for evaluation for this. Do you have any information from Penumbra as to why you guys specifically wanted to do this study?
Yes, so to dovetail on what Kush said, there's a lot of clinical trials, some very good randomized data, but the information obtained in the clinical trials is one type of data, and there are other data sets that we don't often look at, and that those data sets have to do with length of stay, length of ICU stay, where patients are discharged to, economic benefits. And so by going retrospectively with some of the large GPOs, we can get access to thousands of patient data. And it's a different type of clinical research project, actually. So the data points we're looking at are different. And this, as Kush mentioned, is really focused on healthcare economics and resource utilization. And I would like to just point out the data that we're using in this study is from Vizient, which controls about 42% of the hospitals in the United States. Within Vizient, there's an analytics group called SG2. We contract with them. They actually own the data. It's not Penumbra's data. So one of the things that distinguishes this research from a lot of other market access research projects you see is that this isn't data that we take, we cull through and manipulate to have the outcomes we want. They actually have a medical board. They review everything, and we give them guidance on what we want to look at, and we help them with coding. We help them with propensity matching, but they actually do the analysis for us. So there is a checks and balances in place there to prevent an overly biased report by the person or company contracting with Vizient. So I feel really good about the data. I know that we actually end up contracting to get it, but they control it, and they won't release anything that their medical team doesn't think is really valid and worthwhile. So
That's great. It's nice to see very user-friendly data that's not going to be swayed at all by industry. So Kush, very excited. What are the results of this? What can we expect to see in your presentation?
Yeah, I mean, so in brief, what we found is that when patients are offered, thromboreductive strategy, endovascular treatment, and specifically with computer-assisted vacuum thrombectomy, because that's what we looked at. We didn't look at all the strategies. You saw that patients were much more likely to go home then into extended care, subacute rehab, nursing homes, that kind of thing. And what that means is a reduction of cost. And it sort of makes sense. We don't directly show this because it's again data that we don't have all the discrete information that you would like in an ATTRACT trial or something like that. But what it suggests, and certainly it dovetails based on what we've seen in large trials like ATTRACT, is that these patients have less post-thrombotic syndrome, and post-thrombotic syndrome affects patients' quality of life and it affects their mobility. And if somebody has a really swollen leg and can't climb the stairs and can't get around a home that has 2, 3 flights of stairs, then they're going to go to subacute rehab, right? And so this is one of those indirect but frankly strong ways of showing that there's a real material impact on quality of life. And again, one thing to underscore is that compared to other vascular disease, I mean, this is a disease that affects a wide cross section of society. So you have a relatively young patient, a 50-year-old, for example, that has a DVT and then goes on to develop PTS. The time horizon for that impact is, on the order of decades, right? Whereas a typical PAD patient, seventh, eighth decade of life, just typically speaking, in the horizon of impact on quality of life is significant, but on sort of their economic impact on society is less so. So, again, all sorts of places that this could go that, future analyses can look at.
Yeah, I mean, that's just so fundamental in the type of research that we do that allows us to really cater this towards our referring doctors, particularly the ED, primary care, um, hematologists, about shorter hospital stay, faster discharges, discharges home. So it's a huge cost savings, which will really help hospital admin support the use of thrombectomy for our DVT patients. Jim, anything to add?
Yeah, so, along with all those points, I think, and I think it might have been mentioned earlier, but a big point to mention here is that of potentially treatable patients with iliofemoral DVT, it's really only a small percentage of patients that get offered any type of escalation of care. So these type of studies where we can impact resource utilization, looking at large numbers, everything propensity matched, our ultimate goal here is to grow this space. We need to go from offering treatment to 20% of the potential patients to a much, much higher percent so we can avoid these problems with the post-thrombotic syndrome that Kush alluded to. So that's one of our ultimate goals here is to say, how do we get more people um, the therapy they need? And that's especially true in younger patients.
Yeah, of course. Any future directions that you plan for this data set?
So as we move forward, we have a lot of projects that we want to grow from this. This is really a living project that's going to continue on because our technology, the CAVT technology, was just recently released. In a year or two, we're going to have many more patients. And as we look at these studies, we can refine our endpoints, learn from previous um, insights that we had to really refine this and make this more and more valuable. And it's really through the help of concerned physicians that are dedicated to venous care, like Kush and his colleagues, that we're able to do this. We need their help, but I think as we partner together, there's a lot more we can get out of this by refining this data and looking more forward in the future.
Are you able to see more long-term information from this data set, readmission rates, things like that, rather than just a single snapshot?
We can't what we can't see is we can't see office visits and things that happen between hospitalizations. So we can only see what happens in the hospitalization. We can look at readmissions, for example. But if a patient went, so one limitation, for example, is if you came into my hospital on day one and were readmitted to another hospital on day 30 or 60, that would be something that we wouldn't be able to track well. So there are some limitations. Ultimately, we can look out at readmission rates, and we just have to understand that there may be some limitations. Patients who are treated in office-based setting, for example, wouldn't show back up in this database.
Kush, any last thoughts?
No, I mean, this is exciting, right? As somebody dedicated to the space, as a researcher and an active, clinical provider in this space and someone that's dedicated their career to this. Um, I can tell you that the whole idea of real world data is exciting, right? Because we finally have technological advancements, we have data source refinements that allow us to do these things that, Jim will tell you, a decade or two ago simply weren't possible, right? And so the only way you could get even some sort of truth out of it was to run an expensive RCT, which, nobody's saying those things are not important. They're highly critical, right? They're bias limited, but they don't always tell the full story because it's a very refined and sort of enriched population, whereas this really tells you what's happening with the boots on the ground. And then you take those two sets of data and, the outcomes and the results of those data, and you have sort of a much clearer picture of what's actually happening. So I'm just thrilled and honored to be a part of it.
Well, thank you both so much for joining me today. I look forward to the paper.
Thank you.
You.